schizophrenic illness. And that is true for all others. لكن in clinical practice, as I said, we usually say schizophrenia, and we don't resort to the types unless it is quite obvious. Sometimes it becomes obvious. لأنه in case of paranoid schizophrenia, usually the persecutory delusions, which are systematized persecutory delusions, may become more apparent. Systematized معناها إيش؟ معناها إنه هو holding to his delusion. لو حاولت تنقبها معاه أو تناقشه فيها بيطلع لك بديليوجنز ثانية عشان يبرر الديليوجن الأولى، وتكون ديليوجن مرة أخرى مبررة للأولى، وبالتالي تكون some form of systematized، وأحيانا كمان فيها شوية لوجيك. وبعدين لو ناقشته كثير هتطلع أنت المجنون مو هو المجنون في النهاية. Because he talks in a semi-logical way, convince you. The most apparent is the persecutory, systematized persecutory delusion. And it is the commonest form nowadays. Previously, this epiphrenic form and catatonic form are the more prevalent or prevailing. Now it's the paranoid form which is more prevailing. Usually in the paranoid form, we said the systematized persecutory delusions and hallucinations, usually auditory, are characteristic of paranoid schizophrenia. Here, usually personality is more preserved. يعني تحس إنها more benign than the hypophrenic and the catatonic type. بتحترم الشخصية شوية، بتترك آثار طيبة بالشخصية لأنه بتظهر at an older age, usually at an older age comparatively to the other two. Hypophrenic type هذا اللي most destructive of all. الأمريكان بيسموه disorganized. في ICD-9 أو International Classification بيسموه hypophrenic. بترجموه ما بعرف هل الترجمة صحيحة ولا بصام الشبابي بيقول عليه. لأنه هو فعلا بيظهر في أوائل الشباب. هذا these of young patients. يتميز بالثوت disorder. كل أنواع الثوت disorder اللي شفناها اللي بتنتهي eventually ذكرنا كلمة weird سلط أو حاجة شكلها تنتهي بأنه كلامه يصير سلطة في النهاية. يعني شيء عجيب. And odd behavior, all sorts of odd behavior. يعني any socially embarrassing behavior من الحاجات الاجتماعية المحرجة. يتكلم زي ما عايز، ما عنده احترام للآخرين، بذاءة، فحش، يشحت في الشارع هو ما محتاج غيره، كل الأشياء اللي ممكن يعملها. He shows all types of odd behavior and thought disorder. An early onset, as we said, a poor prognosis and disintegration of the personality, and both of them are becoming rare. Epiphrenic and the catatonic type. And this is for both of them. These are the characteristics of both of them, epiphrenic and the catatonic type. Only that the catatonic type is different by the motor signs, the movement disorders, which we have just mentioned. The fourth type, the so-called undifferentiated, أنا بفتكر ده هو الملاذ حقنا احنا دائما we write undifferentiated schizophrenia لأنه أنا قادرين to put one of those types. It's a mixture of the above. The undifferentiated is the mixture of the above. This is the most common. فيه من كل الأشياء دي. There are other types, the one called simple schizophrenia, controversial فيه جدل كثير، وده اللي ما بتظهر فيه any delusion or hallucination during the course of the illness، لكن it ends up by full deterioration of the personality or disintegration of the personality and deterioration in occupational and social life. بيسموه simple schizophrenia. It's not simple لكن مسماه كده لأنه في النهاية من أسوأ أنواع الschizophrenia. And there are other types mentioned in the classifications. I'm not concerned about them. Now when we talk about etiology أنا أفتكر إنه بتسرع شوية. العامل الوراثي أمس ذكرناه. I'm not going to mention it more. إنه definitely there is a hereditary element. Schizophrenia is inherited because it runs in families. تظهر عوائل بصورة معينة. كلما قربت القرابة كلما زاد احتمال وجود. That's why it's more apparent in identical twins. It's more apparent when the two parents are schizophrenic. It's again, it appears if one parent is schizophrenic. Less common when a sibling هو أخ أو أخت is schizophrenic, and it goes like this. Unless when a cousin نعم أو ابن خالة أو غيره is schizophrenic. وكلما بعدت القرابة كلما قل الاحتمال. العكس صحيح. Definitely there is a genetic predisposition, but we have not to forget the environmental factors. لأنه حتى قلنا في الidentical twins توأمين المتطابقين probability is a 50-50 probability maximum. يعني 50% إنه لو one twin he gets schizophrenic, the possibility that the other twin gets schizophrenia, a 50-50 possibility. Where is the rest 50%? Here comes the environmental factors. بتجعل واحد schizophrenic من identical twins and another non-schizophrenic or not schizophrenic. Here environmental factors. These environmental factors start when our patient is still in utero. بمعنى أنه some form of infections in the pregnant lady are found statistically to be related to the child becoming schizophrenic later on. طبعا دي by follow-up studies, longitudinal studies. They follow children who were born to mothers who suffer from certain type of infection, particularly certain viral infections, retrovirus, right? And some other infections like toxoplasmosis and rubella. That's for the pregnant lady. They appear, the children may get schizophrenia later on. May, I said, not all of them, of course, definitely. ولاحظوا إنه الولادات في الشتاء أكثر عرضة لديفلوب سكيزوفرينيا من الولادات في المواسم الأخرى. طبعا المسألة دي بالنسبة للسودان احنا ما معنيين لأن أصلا ما عندنا سيزونز، ما عندنا فصول أصلا، السنة كلها واحدة، صيف عندنا، الدنيا مصيفة بس. لكن في البلاد اللي فيها الفصول واضحة يقول لك الولادات في الشتاء معرضة للسكيزوفرينيا أكثر، أو الناس المولودين في الشتاء معرضين للسكيزوفرينيا أكثر من الفصول الأخرى، والمسألة دي وجدوها in the two different poles, the North Pole and South Pole. يعني studies عملت في الاسكندنافيان countries، نرويج والسويد وفي انجلترا، وستاديز عملت في ساوث افريكا في جنوب افريقيا. الاثنين برهنوا انه مواسم الشتاء تعرض للسكيزوفرينيا اكثر. Now we're finished. Baby is in the perinatal period now. Obstetric injury or complications may precipitate some form of schizophrenia in some patients. يعني any perinatal complications like uterine atony, preeclampsia, and the rest of these complications may lead the patient or the child to develop schizophrenia eventually. And this is called, still we are in the environmental factors around the pregnancy and the perinatal period. The social adversities اللي هم life events, different life events، الحاجات اللي بتحدث للإنسان تقلبات الحياة اللي بتحدث الإنسان after being born may play a role, and the stressful life events, as we have said, may trigger the illness, not causative, what they may trigger is يثيروا المرض للشخص المتعرض له. وجد إنه schizophrenia usually is sometimes preceded by childhood cognitive and social impairment. And children who may later develop schizophrenia may show some form of social impairment. يكونوا من ما هم صغار كده منعزلين، فيهم certain oddities أشياء شاذة يعملوها and what they call soft neurological signs. ما ندخل في التفاصيل، لكن they are somehow different from children who may not develop schizophrenia later on. Schizophrenic patients, even before the onset of schizophrenia, قبل ما تحدث schizophrenia, structural and functional changes are detected by the most recent neuroimaging, like MRI and functional MRI and all the rest. They showed that the temporal lobe, particularly the medial part of the temporal lobe, as well as the frontal lobes, both of them are smaller in size. The brain is smaller in size. The connection between the temporal lobe, there is some form of disconnectivity between the temporal lobe and the frontal lobe, even in patients before they develop schizophrenia. And this, the neurochemical disorder اللي هو بناء عليه بيعتمدوا أخونا شريف in developing drugs، وده جاي أدوب يعني فلازم أدخله في الموضوع. The neurochemical disorders إنه تسمع بأنه dopamine, serotonin, and glutamate are somehow disturbed. The mechanism is somehow disturbed. The mechanism of these neurotransmitters is somehow disturbed, and accordingly, they develop drugs to treat schizophrenia. So these neurochemical disorder may accompany the structural and functional changes in the brain. We mentioned this diagram فقط لتوضيح الكلام اللي كنت بقول فيه عن الاتيولوجي. هي this represents the age of the person. طبعا منكس لانه الصغير افضل من الكبير يعني ينكسوا لأرذل العمر عشان كده عاملين القوس لتحت. Before birth, at birth, the adolescence period, and till death later on here. ده بيمثل العمر. ده بيمثل الفاكتورز that develop that makes the person likely to develop schizophrenia. Probably may develop schizophrenia. It happens this way. زي ما ذكرنا before birth, neutral infections or complications and social adversities to the lady, the pregnant lady herself, and some say nutritional deprivation, malnutrition happening with the lady. Until we end up in a child or a newborn with some form of abnormality in the brain, in the early brain development اللي ذكرناها قبل شوية. إنه the volume of the brain, temporal lobe, frontal lobe, thalamus, all are found to be smaller than the control, the normal control. Through a maturational process, كلنا نعرف إنه البرين develops even further after delivery or some years. Actually, it will not end, the development of the brain continues until late adolescence. But during this development, during the maturation process, there may be impaired development showing reflected in impaired behavioral and intellectual and motor activities of the child. Later on, here this is adolescence, and here schizophrenia breaks in at late adolescence or early adulthood because of these precipitants, some form of stresses, as some form of critical brain event we don't know, just like when epilepsy happens for the first time in adulthood, or the doubling with drugs, psychoactive drugs. أمس شاهدنا زميلنا الطبيب قال أنا بستعمل منشط الأمفيتامين as a trigger or a persistent for schizophrenia for those who are predisposed to develop schizophrenia. And the disease continues to progress by some form of neuropathology called plasticity and kindling and all these things. We don't involve ourselves in details. But anyhow, it shows clearly that it's a developmental issue. That's why they call it neurodevelopmental theory of schizophrenia. In the course and prognosis, have I taken more time, more than I should take? Shall I continue for just 10 minutes? Okay. We come to the course and prognosis, which is important for us. The course is variable. The course of schizophrenia is variable. أنا رسمت صورة قاتمة في البداية، خليني أرسم صورة متفائلة أكثر، خاصة برضو مع مجيء الأخ شريف والنيو دراجز والحاجات دي. The prognosis of schizophrenia has improved a lot. And when we talk about 20 years ago, when we were working in Britain, most of the patients are hospitalized. They don't أبغادروا المستشفى أبدا. They don't leave the hospital. They don't depart. They continue to deteriorate. A lot of things happen to them. So for disintegration and deterioration والزلزال اللي حكيت عنه في البداية اللي بيهزهم كل مرة وكل ما هزهم ترك آثار متبقية، أو البركان أو الفولكانو النائم كلما ثار ترك آثار إلى أن يدمر شخصية الإنسان مرة واحدة. This picture started to change. هذا بفضل الله أولا يعني، لكن we don't know if treatment ولا nature of the illness itself has played a role. Maybe both. Maybe both. The introduction of a new form of management and treatment and medication, and the nature of the illness itself. لأنه في in history illnesses that has been before and now they disappear totally. يعني تعرفوا أشياء أكثر مني يعني in the physical illnesses and organic illnesses. Now, what is the course of the illness? Some patient remit spontaneously and fully, and schizophrenia or the episode never recurs. ما بتحدث لهم مرة واحدة في حياتهم. Only once in life. تحدث ما تجيهم مرة ثانية إطلاقا. And these are about 20 to 25. يعني حاجة كويسة إنه طلعنا ربع على الأقل من الضحايا يعني. تحدث لهم مرة واحدة with or without treatment. ما بيفرق إنه يروحوا للطبيب ولا يروحوا للشيخ. هي حتضرب مرة واحدة وبتروح منهم. في الحالة دي الفضل بس بيد الله يعني، ما هو بيد المعالج الشعبي ولا هو في يد الطبيب. طبعا الفضل بيد الله حتى في العلاج، لكن so 2025 they remit fully and it never recurs. For the other kind, there are remissions and relapses. That means the episode subsides and then again it recurs. وده اللي حكيته عن الزلزال المستمر، كل مرة يضرب، كل مرة يترك آثار سيئة، كل ما ضرب كل ما ترك آثار سيئة. لكن even these are at stages. If the episodes are short and they are managed, treatable, they leave less effect. يعني بيأثروا على الإنسان بصورة أقل. لكن if they are for long periods, they leave behind some form of destroyed aspects of the personality and the social and occupational. Whereas still, and this actually constitutes حوالي تلتين يمكن. وده المجال اللي ممكن ينجح فيه الناس اللي بيتدخلوا in the care of these patients. من الممرض للصيدلي حتى الأهل. هنا مصدر تدخلهم. This is second stage. Third stage غير الأولى لكن الجانب العكسي. They continue to deteriorate no matter no matter what you do. تديهم في التريتمنت وتديهم في الأولانزبين ريكسا وتديهم كلوزابين ما هو فارق كثير يعني لحد الآن ما هو فارق كثير معاهم. برضه تعالجهم بالرقية وتعالجهم بكل شيء، والرقية يعني عند الناس الصالحين تفيد أكثر يمكن من العلاج لكنها برضه ما بتفيدهم بشيء. Continue to deteriorate. A downhill course. متدحرجين من النازلين من الجبل أيا كانت. Fortunately, this constitutes about 10%, even less now, probably. Maybe even less, 10% في the statistics في ال 80s. أنا هسا نتكلم عن 20 سنة مضت. We expect that we take some of these to the second stage. Some of those who progressively deteriorate to those with remission and relapsing. شوي شوي ناخذ منهم آملين بأنهم يخلصوا النهاية وما يفضل حد فيهم. Something which is forgotten. Schizophrenia comes next after depressive illness in committing suicide. يعني كثير من الناس ما هم رابطين بين السكيزوفرينيا and committing suicide اللي هو الانتحار. بيربطوا دائما بين الاكتئاب والانتحار، لكن ما يربطوا بين السكيزوفرينيا والانتحار. But here it comes next. 10% suicide, 15% in the depressive illness they commit suicide. وبعدين أحيانا when they try to kill or themselves or harm themselves they don't know why. أنا أتذكر واحد من المرضى very chronic patient. فجأة جاله محل نفق عالي جدا ونزل طيح نفسه من فوق. طبعا many fractures or complicated fractures or comminuted fractures وشيء complications رهيبة. He did not die. فمشينا هو كان مع أهله لكن سمعنا به مشينا نشوفه في المستشفى. very simple question سألته ليش سويت في نفسك كده؟ ما هو عارف. doesn't know why did he try to commit suicide. A serious comment, a serious trial on himself, a serious attempt. These are the factors for course and prognosis of the illness. It's the good prognosis, here the poor prognosis. Sudden onset اللي بيشتعلوا like an erupting volcano suddenly with very acute onset خاصة إذا كان في نوع من الستريس سابقة. good prognosis. Sudden onset. Short episodes. If there is no past history, this is the first episode. If there are affective symptoms, for females, as I have mentioned, they are on the good side actually, not on the poor side as we are. And in old age, better. And those who are married, دي حاجة حسنة طيبة تضرينه شراركم عزابكم. In the stable personality. In those who have good work records, غالين ومستقرين وغيرهم. And in good social relationships, good compliance اللي هو التزام بالعلاج تمام and negative family history if there is no family history. These are factors of good prognosis. Factors of bad prognosis, some of them are just the opposite of the first, and there may be some addition. Or more, most of them actually, if you have a look at them, sequence onset, long episodes, positive past history, negative symptoms, or affective symptoms, males, young age, as opposed to old age, the single, the divorced, and the widowed, the abnormal personality, the poor work record, the social isolation, and poor compliance and positive family. Stand for bad prognosis. ده sketch بس للمانجمنت. we don't know بيكون في ورك شوب mentioning drugs. الدراجز احيانا الجديده بتكون صعبه كده، المسميات بتاعتها صعبه. لكن we may not mention them. فقط بنوري السكتش انه how to treat such a patient. اول ما جاء المريض first episode we give an antipsychotic or choice. Mainly now there is tendency to use the new generation of antipsychotics. Let me call them new generations. بيسموهم atypicals. منهم ممكن الليل يكلموكم عنهم. لا انتم ما عندكم الا يوم. الليل ممكن يكلموكم عنهم. part of them. الحين كويس. olanzapine is one of them. clozapine is another one. risperidone and some other drugs. أنا زي ما قلت إذا زحمتكم بالأسماء بتصير مشكلة. They start to choose this one when they left aside Valjartil or Stelazine or Serenase, and now they're aside. لكن لسه availability of these drugs is not that they are not that abundant in the pharmacy, and كده still we resort to the old drugs or the typical antipsychotics. فإذا give antipsychotic, optimize the dosage, ارفعها للقدر المطلوب, and assess in 6 to 8 weeks. شهر ونص لشهرين. If the treatment fails, يكون واحد من اثنين. إما there is poor or no response despite full compliance. المريض بياخذ في العلاج لكنه حالته ما تحسن. أو يكون في poor compliance ما بياخذ علاج بسبب ما. أو يكون غير محتمل للعلاج because of the side effects of medication. Well, this is another side يمكن الدكتور شريف may talk about it. Some drugs are more tolerable than others, or especially probably the new drugs are more tolerable than the old ones لأن عندهم side effects كريهة. منها اللي شفتوه أمس زميلنا أخونا شادي extra abnormal side effects وغير الأشياء الأخرى hyperprolactinemia and the rest. But in case of poor response in spite of full compliance, يعني patient بياخذ العلاج وما بتحسن, you may switch to another drug. لأنه خلاص وعذرت لأنه أخذ العلاج لفترة كافية. But you have to switch to another drug. You have to try it again and assess it in 6 to 8 weeks. And if there is no poor or no response, many advise that you switch to a drug called clozapine, and you assess it over 6 weeks. Yeah, 6 months actually. The first 6 months. clozapine. واحد يقول له ادينا مثلا ادينا كلوزابين نعمل ايه والمريض ما تحسن. والله الشكية لله بعد ذاك يعني. ما عندنا. in case of poor compliance and or poor tolerability ما محتمل العلاج, you have to discuss it with the patient. ليه ما بياخذ العلاج؟ ودي طبعا حاجة طويلة يعني. eventually إذا كان اقتنعت إنه المريض ده ما حيستمر ماخذ العلاج, switch to another drug or give him a Diego injection اللي هي بتعطى كل شهر أو كل أسبوعين, وعشان كده ممكن تكون ضامنة أكثر لأنه ممكن يجي في العيادة وياخذ الإبرة ويروح. يكون ضامن إنه هو ما أخذ العلاج أو ما أخذ جزء من العلاج. Unfortunately ما في Diego injections except for risperidone among the new drugs. Again, you assess over 6 to 8 weeks وتمشي بالسيم poor or no response للموجودين. بعد 6 months تشكي بثك وحزنك إلى الله إذا كان ما في response. Now, patient improved on the first episode and then he relapsed. جاته الهزة الثانية. نسوي إيش؟ نحاول to investigate social or psychological precipitants. يمكن في أمور اجتماعية أمور نفسية حصلت هي السبب في أنه هذا الريلابس لأنه he responded very well to drugs at first. السبب إيش؟ And you give support generally or supportive psychotherapy, and then you continue the drug treatment, the same drug treatment لأنه he had a response. If needed, you may add sedatives, form of adjuvants, benzodiazepine or otherwise. Or if you think that this is another choice, you think that probably the relapse, because the drug has not been effective enough, first drug, you may switch to another drug and assess over 6 weeks, and if the treatment is ineffective, switch to clozapine again. This is the relapse. First episode and relapse. And problem of poor compliance دي كانت تحتاج لنقاش كثير فعشان بس نحطها لأنه كانت ذكرت. There is poor compliance. The patient is confused or disorganized or lacking insight or support or having poor tolerability to the drug. These are the reasons for lack of compliance. أشياء إنه ما محتمل العلاج، إنه بسيط ما مستبصر بمرضه، إنه confused، إنه disorganized زي الهيبوفرينيك سكيزوفرينيك، كلها تحتاج ل what is called compliance aids. تدخل الفاميلي، تعمل في أشياء كثيرة تتعمل في المسألة هذه. And give a depot antipsychotic لأنه الوحيد اللي يضمن لك، or switch to another acceptable drug إذا كانت المشكلة البور tolerability. ده السكتش العام للتريتمنت without mentioning drugs. And the psychosocial management I just mentioned them. ده الريهابيليتيشن اللي بيتكلم عنه دكتور عاطف أو اتكلم عنه قبل شوية، إنه الدراجز عالجت الأعراض النشطة called positive symptoms, and we were left with the negative symptoms, social withdrawal, apathy, التبلد العاطفي اللي ذكرناه والبلاد العاطفية اللي قلنا more destructive to the patient. كيف نقدر نعالجها في حالة إنه العلاجات وقفت عند حد معين ما زادت عليه بالنيجاتيف symptoms. نعالجها بالpsychosocial treatment, which may maximize the abilities and minimize the disabilities and prevent relapse by family therapy, by group therapy, and these are all types of things which are done usually in hospitals, not in مركز. لكن, and I think you have a chance at least to educate the patient about the illness and to educate the family about the illness and to try to change the attitude of the family towards the patient and the illness. حتى في المراكز الصحية يقوم يشب في حلقي جعفر يقول احنا ما عندنا وقت ما بدي عذر بترك الامر. فعلا كلام صحيح انه ما في وقت، لكن يعني الناس اللي بيجوا الصباح ديل بيجوا يفتتحوا حاجات دي ويكونوا لابسين البشتات لا مؤاخذة يعني لابسين البشتات الجميلة دي والاشياء دي، المفروض يستمعوا للاشياء اللي بتتقال هنا، وانتوا الناس اللي بتغيروا المفروض يستمعوا لها عشان يتدخلوا يسووا لنا شيء معين عشان يغير لنا الامور. هذه بالطريقه دي اقفل الكلام على جعفر يعني. I finished. Thank you very much. I'm sorry for the time which I have taken from you, your valuable time. لكن this is a very important issue. I finish by the fact that أكثر مرض بيحطم الإنسان بنظري illness like at least and other physicians or schizophrenia. This is an illness that needs a lot of work to be done. And it is still an enigma. شيء غامض أسطورة ما زالت رغم مع المعلومات الكثيرة اللي وجدت حاليا عنها برضه تظل أسطورة ما ندري ما هي أو what is schizophrenia. And with that I finish and rest my case.
الله يجزاك دكتور عثمان. لي أسئلة.
أنا ما أخذت مثال. Sorry.
Yes, excuse me. Thank you, Dr. Osman, for this lecture. I just want to ask about the full remission phase.
Sorry?
The full remission.
Full remission, yes.
Yes. Up to how many years you can say that this patient develop a full remission? And the relapse phase, every how many months we can say this is a relapse?
Regarding the full remission, this is there is a lot of controversy, جدل كثير and discussion نقاش داير حول المسألة هذه. لأنه if about 25% as I said or 20% لو تشاءمنا, if you are pessimistic, so we say 20%, they have full remission without treatment, without our intervention. Why should we intervene and say, well, he may have a relapse, let me treat him? أكون أديته لا مؤاخذة side effects more than treating him. But if the patient hasn't come to us, أنا بفتكر هذه المسألة اللي إن شاء الله بتريحني وبتريحك, إنه البيشنت he did not come to us and he became well والموضوع انتهى. لكن if he comes on the first episode بيخلينا في مشكلة إنه shall I discontinue the treatment? He had full remission. Shall I discontinue the treatment and leave things aside and continue to follow him up, the outpatient, to see if he will have a relapse or not? Or shall I continue on treatment? هنا بدور الجدل لحد الآن. ليه؟ لأنه إذا كان أصبح من ال 25 أو من 20 20% الربع أو الخمس, أنا بكون مديه علاج unnecessarily. وما هو علاج؟ Very strong chemicals and psychiatric drugs. مع المعذرة يعني. فليش أديه؟ This is the point. إذا كان أنا ما ضامن إنه he'll have a relapse or not. في اعتقادي إنه the first episode, even if it's by treatment or spontaneous, يعني without treatment, just give the patient a chance for follow-up, or say a year, 1 year, or even 2 years. He should come to you. لأنه we don't know if a relapse will happen and when. At least give him no treatment, follow him up and see if, or follow her up and see if a relapse happens, then you have to interfere. If no relapse happens, you continue أنك تحمد الله على ما فعل. After 1 or 2 years, usually they say 9 months sometimes, to make sure, 1 or 2 years, you may say to them, I think your young man or your young woman, lady, may not have any relapse, inshallah, and you discharge her from the outpatient. So you are not giving her medication, but you are following her up. And that's the only answer for the time being. And although there are some characteristics for those who will have only 1 episode, but these characteristics are not definite. You cannot say definitely those who have such and such characteristics will have only 1 episode and will have it only once a time in life.